Hello everyone. We will continue with our discussion to crack the question banks for the medical board exams. So, if you get a patient who's like 44, have cirrhosis, okay, due to alcohol or fatty liver or whatever reason, so you do regular labs on them. You do regular lab, you see creatine, it's like 2.1, okay? So, cirrhosis, creatine 2.1, they tell you what's the best next step. This is most likely hepatorenal syndrome. So they tell you, okay, how do you manage it? You give IV albumin. And that brings us to the discussion of hepatorenal syndrome. There are things that precipitate that, like infection, spontaneous bacterial peritonitis, gastrointestinal hemorrhage. If there is oliguria and a progressive decline in renal function, can precipitate that. A fraction null excretion of sodium less than 1%, this person the hepatorenal syndrome. If there is advanced liver disease with portal hypertension, if there is acute kidney injury without a clear explanation, or if there is a bland sediment on urinalysis, and usually there is no improvement in volume expansion, and the trial of volume expansion. So when you give, like, usually you have low blood pressure, cirrhosis, patient looks swollen, abdomen is distended. It's very tricky, because they're intravascular depleted, but extravascular, like a lot of fluid in there. So you give them albumin to attract the fluid inside the vessel where it's supposed to be. The management, other management, you can do midodrine, octreotide as well to compress the vessels. And then you can do norepinephrine in the ICU if these doesn't work. And the best definite management is transplant. Just give them a new liver, their liver is like destroyed, And the MELD score, usually you can use that to predict 3 months survival following tips, which take into consideration the bilirubin, INR, and creatine, okay? So the reason that if you get idea of MELD score, this give you idea. If it's above 18, this means there is 3 months survival, okay? So you can decide, like, are you gonna do transplant for just like to live 3 months and die? So just to be cognizant about that. Alright. Now, this patient, that's why I love medicine. It's very interesting, Somebody with chronic kidney disease, creatine is 7, and they have nosebleed. So why is that? So we said the kidney and liver, the relationship here. Nosebleed, even though there is a platelet doesn't work, so increased risk for bleeding with a chronic kidney disease. So what would you do? Best next step. This is platelet dysfunction, kidney disease. The one you give desmopressin, okay? When you have kidney disease, the platelet could maybe stop working. So what is the pathogenesis of that? There is rising urea, upregulation of nitric oxide, decreased platelet activation, adhesion, and aggregation. And the clinical feature, you have easy bruising, mucosal bleeding like epistaxis, GI hemorrhage, And lab findings, you have normal platelet count, maybe mildly low, normal coagulation studies, okay? And how do you treat it? You treat it only if symptomatic or there is a procedure coming up, And the first line is desmopressin. Now you ask me, how does it work? Desmopressin, it stimulates the von Willebrand secretion from the endothelial cells. So this stimulates the platelet function, like encourages the platelet to adhere and repair the bleeding. The second line, if it's like completely destroy, you can do dialysis to fix the kidney or anemia correction, okay? If refractory, then you can do conjugated estrogen or cryoprecipitate, which is stimulate that platelet as well, okay? And there is very beautiful pathophysiology for the platelet dysfunction and chronic kidney disease. When you have kidney disease, the ammonia is going to go up, right? So when the ammonia go up, this ammonia can go to transform to arginine, amino acid, and that arginine stimulates nitric oxide, and that nitric oxide decreases von Willebrand secretion, decreases thromboxane A2 secretions as well, and decrease G2B 3A receptor activation, which is required for platelet adhesion. So all of these are required for platelet function to stop the bleeding. So if you stop all of those, you won't have platelet activation. Platelet will be lazy. You see there are platelets there, but not working. All right, now this is another case. It's a pretty interesting case. You see, 64-year-old man came in with confusion and weakness. There is on exam there is left hemiparesis from prior stroke. There is left hemiparesis from prior stroke. So you examine the patient. You see creatinine is like 2, okay, and then you do your analysis. You see 4 plus blood. There is a blood, but erythrocyte will be only 0 to 1 erythrocyte. There is one situation that causes that. You see blood in the urine, but no erythrocyte. This is very high yield, and I've seen a case like that actually. So this should trigger you, like if somebody has just recent confusion, I had a stroke recently, and then now become confused and more weak in the past few days. Okay, then you want to check the creatine kinase because this could be why. What's the diagnosis? Because this could be something called rhabdomyolysis, especially after stroke. They don't move much, you know. So it could cause kidney damage, confusion, all of these symptoms. So you will have creatine kinase above 10,000 often, and then on urine test you see red to brown urine with positive blood but no RBC. That's what we call myoglobinuria. Amazing. Electrolyte, you see hyperkalemia, hyperphosphatemia, hyperuricemia due to intracellular electrolyte release. You can see hypocalcemia and dehydration due to influx of calcium and intravascular fluid to injured muscles as well. And the creatine will cause AKI due to tubular injury from myoglobinuria. Okay, you have AKI. And fraction excretion of sodium can be falsely low as well. Okay. All right. Now this case is a pretty interesting one as well. It's high yield. You see someone who's 76-year-old came in with confusion of 1-day history. So you take more informations, right? You find out that the patient has congestion and using OTC medications, okay, over-the-counter medication. So which one out of the counter medication that causes that treat for congestion, you know? You use pseudoephedrine, right? So now his confusion and with history there's some congestion taken over the counter medication. So this put it on your suspicion, right? Now you do examine the patient. They tell you palpable mass in the suprapubic region, okay? There is palpable mass in the suprapubic region and the creatine is a little bit elevated, 1.2. And they tell you, okay, what's best next step? You gotta know the diagnosis to know what's the best next step. So this could be urinary retention. So you want to do urinary catheterization. Okay, you want to do urinary catheterization because this could be urinary retention from the pseudoephedrine. Or antihistamine as well. Why? Because this patient could have underlying benign prostatic hyperplasia. So when you have antihistamine or pseudoephedrine or diphenhydramine, these have anticholinergic properties. So it makes it hard. It's already hard for the bladder to pee because of the obstruction and the benign prostatic hyperplasia. So this one, it relaxes the bladder, so it makes it even harder to pee. So you'll have confusion and urinary retention. And usually you need to do bladder ultrasound. If it's more than 300 ml, you do catheterization, okay, after bladder decompression. And urine retention is very important cause of delirium, okay, and usually symptoms improve significantly after you put the cath. This is lifesaver. Alright, now this is another interesting case. You see 38-year-old man comes in, he had acute alcoholic pancreatitis. Alright, over the past 12 hours, okay, what happened in 12 hours? Urine output decrease and creatine increase, like from 1.1 or 1.2 to 2.2. So this is a big jump in creatine. Okay, so what do? You do exam. You go to examine the patient. What's going on? You see that you're doing rounding, follow up next day. You see diffusely tender and tense distended abdomen. Diffusely tender, tense, distended abdomen. There is a crackles, JVD elevation, decreased bowel sounds. Okay, 3+ pitting edema. And what's best next step? They ask you. This is a tricky and can be missed, and this can be life-threatening as well. This one, somebody who have pancreatitis now, they having like, so when you have inflammation and pancreatitis, this could cause something called compartment syndrome, and that's what it is. And now there's high suspicion for it. Abdomen is tense, distended. So what you would do, you really need to measure bladder pressure, okay? Because there is a risk of compartment syndrome, okay? So to measure bladder pressure, to tell you, because bladder pressure could give you an idea of the abdominal pressure. Once you measure that, then if it's, because you suspect that, you want to rule that out. This is risky, you know. So this happened in high-risk patients, like somebody who had trauma or burn patients, someone with liver transplant patients, abdominal disease like massive ascites or bowel distension, if there is extensive fluid resuscitation like sepsis, acute pancreatitis, post-surgery with large volume resuscitation as well. These are the high-risk patients. And what are the clinical features? Usually patients too ill to communicate, and you have tensely distended and tender abdomen. You see progressive oliguria with renal injury. Blood pressure drops. You have high heart rate, high jugular venous pressure, peripheral edema, hypoxia, increased ventilatory requirement as well. This is abdominal compartment syndrome. Okay, so and this usually happens from aggressive volume expansion in patients with a trauma or septic shock. You give them a lot of fluid and can cause multi-organ failure and acute kidney injury, okay? Because a lot of fluid, they become fluid overloaded, okay? And a lot of the time, patients will need surgical decompression, okay? So once you measure the hydrostatic pressure of the bladder, okay, to assess intra-abdominal pressure, if it's high, consult surgery, okay? Alright, now this case it's a pretty interesting one too. So this case is interesting. You see somebody who's came in 52, came in with flank pain, pink urine. So you do dysuria, you know, you do regular labs. A regular lab shows calcium 10.8, and they tell you, okay, what do you do now? And then you do CT, you see 4mm stone, okay, no hydronephrosis, and they tell you, okay, what's best next step? Now I just consulting urology. You want to check parathyroid hormone. You repeat serum chemistry and check parathyroid hormone level, because primary hyperparathyroidism is common cause for hypercalcemia and causing renal stone as well. You know, renal stone, abdominal groan, all these things for hypercalcemia thing. Okay. Now this case they give you is it's interesting case. Okay, so 25-year-old woman. Okay, so this 25-year-old woman has infective endocarditis. Okay, you do echo culture, grow E. coli, Enterococcus fecalis in the blood culture. There is vegetation on echo. Okay, so you end up treating her with ampicillin and Rocephin. Now the patient comes back like in a few days. You see creatine increase renal function. And then they ask you why the patient increases creatinine, and then you check regular. So you check regular CBC, CBC PMP, right? So you do in CBC there is eosinophil 7%, right? So there is eosinophil 7%, creatinine is high, calcium is high. So what you do urinalysis as well, okay? What would urinalysis shows? Urinalysis shows blood, shows leukocyte esterase, and shows white PC casts, okay? And then you see white PC 20 to 30 or RBC 20 to 30 as well. So what is the diagnosis here? And they tell you why. This could be due to drug-induced acute interstitial nephritis, okay? This is drug-induced acute interstitial nephritis. So why would that happen? Usually caused by medications like antibiotics, in this case non-steroidal anti-inflammatory drugs, or PPI as well, okay? Other things, rheumatologic disease like SLE, Sjogren's syndrome, sarcoidosis can cause that, or there's infections like Legionella, tuberculosis, or CMV, okay, cytomegalovirus. How does it present? Usually somebody who just has started on new medications, cause acute kidney injury, can cause arthralgia and malaise, can cause skin fever, skin rash and fever, and eosinophilia. Eosinophilia, you can see that. May or may not see that, okay? So that's another thing. How do you diagnose it? You diagnose it usually clinical presentation. And you can see white PC and white PC cast, plus mild RBC and proteinuria. Peripheral eosinophilia and urine eosinophil would be positive. And when you do renal biopsy, you see tubulointerstitial inflammation and edema, okay? How do you manage it? You manage it, you discontinue the offending drug or treat underlying condition. You do systemic glucocorticoid, you do supportive hemodialysis if needed, okay? This is very important. Now you have this patient who's 18-year-old, came in with altered mental status, okay? So you check hemodynamic and stable hemodynamics, like blood pressure, hemodynamics, blood pressure is low, heart rate a little bit high, tachypneic. So what do you check? You check so you do, after doing regular labs, you notice there's elevated anion gap, like sodium 140, chloride 98, or bicarb is 14. So you see anion gap elevated. So there is anion gap, and then you check pH. pH is low pH. This is called anion gap metabolic acidosis. So you check osmolarity, serum osmolarity, high serum osmolarity, okay? And you check the kidney is okay. So what could be causing that? And you check the osmolar gap as well. It's more than 10. So if the osmolar gap is high, this indicates maybe there is extra molecule in the blood that's not supposed to be. So this one diagnosis, it's methanol poisoning, okay? So you gotta know the difference between methanol and ethylene glycol. Methanol is toxic to the kidney, to the eye. That's why it causes confusion and vision defect. You see anion gap and osmolar gap high, elevated in both ethanol and methanol. But methanol affects the toxic to the retina, causes confusion, vision defects. But ethanol causes kidney, ethylene glycol causes kidney damage as well, okay, AKI. There's this ethylene glycol. And ethanol can cause confusion as well. The only one that's a little bit different, doesn't cause anion gap metabolic acidosis, but causes high osmolar gap. All of them cause high osmolar gap because it's extra substance in the blood, and all of them causes elevated anion gap because they interact with the blood chemistry, except one, isopropyl alcohol. It doesn't cause anion gap. There's no acidosis, okay? So, but just cause confusion, and usually happen from rubbing alcohol, hand sanitizers can cause that, acetone, minor toxicity, okay? Ethylene glycol, we all know from antifreeze, okay? Can transfer to glycolic and oxalic acid. That's why it causes metabolic acidosis and anion gap. And we said cause confusion, hypercalcemia, and oxalate crystals as well. And methanol from windshield washer fluid and homemade liquor can cause the formic acid and causes acidosis and osmolar gap. And ethanol from beer, wine, and liquor could transfer to acetaldehyde, which is acidic and causes high anion gap, high osmolar gap, and confusion. Okay, these things that you want to know about. Okay. Now, another case you would see somebody who's 51 comes in with difficulty urination. Okay, so you examine him. There is fullness in both lower quadrant. Okay. So what does that tell you? There is some kind of urinary retention obstruction. Okay, so you do ultrasound. Ultrasound shows urethral dilation. So you consult urology, and then they put a pigtail catheter, and that's all they do. You know, they leave you alone. And then after that, urine output. So there is a lot of urine and hydronephrosis. Urine output 600 cc and over the next 2 hours. Next 6 cc an hour. And then tell what's best next step. What do you give? Do you give a lot of fluid? Because they're losing a lot of fluid. Do you hydrate them 600 cc an hour? Or do you just hydrate them like, okay, like just not too high? The answer is not too high, obviously. You do 200 cc an hour. It's a pretty moderate, good hydration level, okay? Because this is what we call post-obstructive diuresis, okay? Usually, it's from the osmotic effect from retained solutes. So it's retained. Once you have opening, it's gonna bring a lot of fluid with it. And also, there's decreased sodium channel activity with decreased sodium reabsorption, and there's decreased water reabsorption from impaired water channel insertion in the collecting tubule, okay? And you need excessive IV fluid administration in attempt to match urinary output of diuresis. This can cause that. So if you don't give too much fluid, just give a little bit of fluid. If you give a lot of fluid, this is gonna cause a lot of diuresis, and we don't want that, okay? Now, this case is a really good one. So if you see somebody who's 27, who's marathon, this is first marathon, okay, 4 hours and 20 minutes. Woman, okay, so marathon, you run a lot, okay, so you tend to drink a lot of water, and that caused disorientation and seizure. And they ask you, why is that? So she's athletic, she drinks a lot of water, she was running, you know, why is that? This is because, my friend, it's hyponatremia, okay? Because there isn't enough electrolytes, or just water. This is gonna dilute the sodium in the blood, and that causes hyponatremia. You know, we're all just chemical components, you know. So if you drink, this is endurance athletes, hyponatremia can cause that, you know, cause nausea, vomiting, disorientation, and seizure. This is pretty risky, okay? If you ingest a lot of hypotonic fluid. To avoid that, maybe fluid with electrolytes would be a better option. Okay, now let's review what we discussed. We talked about hyponatremia. We talked about how to match 100 cc an hour for urine retention. We talked about methanol, ethylene glycol. We talked about interstitial nephritis, parathyroid hormone, bladder pressure for compartment syndrome. How do you do that? Tense, diffuse tense abdomen. Urinary catheterization is helpful for somebody with delirium. Rhabdomyolysis when there is a blood but without erythrocytes, and like in the urine. Desmopressin is required when there is CKD, platelet dysfunction. CKD, liver dysfunction, you give IV albumin, octreotide, and midodrine. And that concludes our summary of this section. Thank you for listening.